So it's now my pleasure to introduce Jackie Judd, who is the chair of the ABIM Foundation Board of Trustees. She is a communications consultant and an award-winning journalist who has reported for PBS, NewsHour, ABC News, NPR, and CBS Radio News. So let's welcome Jackie, and thank you, Denise.
Thank you, Susan, very much. It's great to have you as a new member of our board, too. So for the next little while, we are going to go into the C-suite, into the ICU, at a patient's bedside, into a homeless shelter. As we hear from healthcare professionals who've worked on the front lines in the last 6 months during the pandemic about what they've learned, sometimes regrettably, about trust and equity in their own healthcare systems. I hope that each of you watched the videos that they had submitted and were posted a couple of weeks ago. But as a refresher, we're going to now show a compilation of those talks. So roll the tape.
How can we properly take care of an already disadvantaged population amidst a pandemic if we cannot properly take care of ourselves? My trust was affected in the healthcare system at the time. Especially since I ended up in the ICU and was very close to being intubated. And things are better now, but we must focus on maintaining these changes in transparency in order to solidify this trust that we have between our providers, patients, and administration and the healthcare system in general, well before the situation worsens.
Elderly woman of color who was disadvantaged financially had survived her prolonged hospital stay with COVID-19. Unfortunately, she came back to my emergency department and I saw her 2 days after her hospital discharge. The ambulance brought her because her outpatient dialysis had not appropriately been coordinated and rescheduled after leaving the hospital. Her trust in our system to help facilitate the care that she required in order to breathe and live healthy had failed her. And thus, her trust was gone in our system's ability to provide for her what she needed. Now, I hope we can build a system that can provide health care equitably to those who need it and at the time when they need it. Then we will have a system that's trustworthy.
One of the greatest challenges we've faced during the pandemic is understanding the most effective treatments for patients. And the word experiment has a strong connotation in the African American community of performing research without regard for the subject's safety or well-being. Scientific objectivity in conducting studies isn't conducive to the establishment of trust. On the individual doctor-patient level, trust is manifest by the kindness and compassion we demonstrate to every one of our patients. But on an institutional level, it manifests as just and equitable care.
Our hospital disproportionately serves low-income patients, including many patients experiencing homelessness. As we expected, our hospital surged quickly. We found ourselves chasing space, staff, and personal protective equipment. The shelters face some of the most difficult challenges. Think vulnerable population in very close quarters during a pandemic. Hospitals in Boston had limited PPE at the time. The shelters had none.
Access, education, support. These are three things that we often take for granted. And what do they all have in common? Health. Many vulnerable populations don't always have access, have the knowledge, or have the support. And then add COVID-19 into the mix. Three things that can change an entire person's life and illness experience for the better or worse.
Thank you all. I invite the entire audience in the forum to continue submitting comments and questions. We will try to get to as many as possible. Let me reintroduce our panelists since that went by pretty quickly. Psychiatric nurse Marcus Henderson, who is in Philadelphia. Resident Andres Maldonado, who works in 3 hospitals in the Bronx. ER Dr. Adam Sharp with KP in Southern California. Pulmonologist Geneva Tatem at the Henry Ford Hospital, and CEO of the Boston Medical Center, Kate Walsh. Welcome to you all once again. As you know, a theme of the forum is to come up with solutions. And so we are going to continue with that theme and ask each of you what might be done better given what you've experienced. Andres, I want to start with you. For the entire audience, Andres may look familiar to you. Nicholas Kristof heard about his situation. He's not only a doctor in the Bronx, which was the epicenter of the pandemic in the earlier months, he himself got COVID quite seriously. And Andres, from talking to you on the phone, from looking at the video, from reading the Kristof column, it's clear that you feel a sense of, as Rich Barron put it, earned mistrust and even betrayal. How do you remedy that? What ideas do you have now for how things might be done better in the near future?
Hi, so thank you for having me on this forum. It's a great honor. So, in terms of my story, just to give a quick background, the thing that really led to me distrusting, the place that I work in the healthcare system was, as we've said over and over, just the lack of PPE, using an N95 for a couple of days in a row. And in terms of, facilities in our hospitals, not having enough rooms, having patients out in the hallways, coughing and sneezing. And, the big thing I feel that what can be improved is we have some systems implemented for patients that come in. We have these policies for certain types of pain. If there's a huge disaster, we have, massive casualty incident. We have all these protocols set in place for something that's so large and, threatening. And, there wasn't anything really for, something like a pandemic, because we haven't had a very serious one for decades. So, that should have been implemented from the get-go early on, even before the thought of a pandemic was in our minds. And, hopefully now that a lot of other states are having their peaks in COVID, they've learned from, our mistakes from other states that already had their peak. So I think, like I said, it's really important to have a system in place before things get worse.
Do you think that there was a lack of preparation in your hospital system, in part because it is under-resourced? You serve an under-resourced population?
Definitely, but I think that stems to a deeper problem, national problem, where, honestly, the whole country was unprepared for something like this.
I have a personal question for you. Can you get back to the place where you were at 7 months ago as a doctor on the cusp of launching your career and the excitement you felt about that? Or has this changed you forever?
I can honestly say this has changed me forever, yes.
In what way?
I can connect with my patients a lot better. We can always understand disease and, the pathways and, how to treat it, but to really feel every symptom and, be in that stretcher and, have oxygen on, high flow, and just, have tocilizumab, just all these medications. I truly understand how frustrating it can be for patients, even though I had a good course and I had great care. I connect in such a deeper level now.
Thank you. Kate Walsh, I want to turn to you now because Andres works patient to patient. You work as the CEO of a large hospital. And my guess is that you have 1,000 different things you'd like to do to change. What's on the top of your list?
I think that Andres' comments are really sort of telling, because when the people who are taking care of patients lose trust in the system that they're integral to, it's a really difficult challenge to climb out of. And I didn't talk about this in the videotape, but there was one Saturday I remember distinctly sitting in the command center, and we changed the CDC guidance on masks, changed 3 times. And so we were putting N95s on units and taking them off and, giving them in the emergency room and then taking them away. And, I think if I was a frontline healthcare worker at Boston Medical Center that day, I would have quit. I mean, how could you trust a hospital that kind of doesn't know what it's doing? And, I'd like to tell everyone on this call that that was certainly not deliberate. And we were responding to the best available information we had at the time. but it was really daunting. And, you know, I think about the 6,000 people who wear this ID badge and think, you know, we really failed them. And some were working at home, so we probably didn't fail them as directly, but and then what do you do to come out of that as a leader, and what does the organization do to come out of that? And I think the only thing we could do was as much information as we had at every moment. So our response or remedy, and I don't know if it worked. I think there's some PMC folks on the call, maybe they can vote later, but after I've signed off. But I think it's really, did information help? And just being as clear and as transparent as we possibly could be, and really kind of, you know, frankly apologizing for what we didn't know, or the absolute, you know, distrust that was created every time we changed because the guidance changed or our supply changed. And I think it got to the point where people like just didn't trust that we could count masks. Yeah. And you're counting in the millions of masks if you think about a year's supply. So it was a very interesting, it was an incredible.
Before the pandemic, Kate, would you have presumed that you and your leadership understood effective communications to the staff? Was this an eye-opener for you?
No, we never presumed that we understood it. I think communication is always a challenge at your business. So I'm not telling you anything you don't know, but I think that, I think the trust element, I think I kind of presumed. And I think, to be frank, we lost it at various points of time. And that's why I told the personal story of it finally dawning on me just how challenging this is for people, and that how the consequences of our actions or inactions, the implications it really had for the people we were really trying to support through this. And I think we're getting better at it, but there's still a ways to go. And, you know, I wish the country was in better shape, but when you hear the stories coming out of the states that are surging now, it's exactly the same problem. 7 to 10 days for tests, burning through PPE, all the things that we were facing early on. It's like there's no learning in this country, which I find really stunning.
Yeah. Marcus, next to you, in the body of your video, you talked about the challenges of working with homeless men. And you cast it in a very big picture frame about education, access, etc. So bring it down through a funnel for us and tell me what your key thought is about what's a solution for that population in particular.
Thank you, Jackie, and thank you to everyone for including me on this panel. Very excited to be here. I think for me, the solution, you know, I've been thinking a lot about that. And it's something that is done in many places, but not in all and not enough. And that's just simply, instead of lecturing and reading articles about disparities and inequities and social determinants of health, it's putting people in the community and using the community as the teacher. I mean, the fundamental issue that man experienced that I talked about in my video was the provider had bias and stigma that provider allowed to judge that individual and dictate that care experience. So it's just fundamentally going in and having those intentional engagements with community to understand the root causes, understand those issues that individuals and community members are facing. You know, I teach in a course at Penn where we take nursing students in the community for 14 weeks at schools, libraries, community centers, senior centers, and clinics to really stop looking at the textbook and look at people for who they are. Stop looking at the PowerPoint and look at people for who they are. That's the real change. People are doing it, but it's not done enough. So we need to begin recognizing our own biases, having that increased awareness about equity, social determinants, and hopefully that would increase compassion and build empathy that Dr. Williams was talking about in his lecture. That's, I think, the fundamental for at least health professions education. We need to begin there.
Thank you, Marcus. It's great to have you with us. Geneva, I want to turn to you. In the body of your video, you shared the story of a patient who you were trying to persuade, in part through their family members, to join in a clinical trial to test a vaccine. And there was understandably a lot of suspicion and mistrust expressed. What do you do about that? how do you persuade underserved populations to participate in these trials, particularly in a vaccine for COVID?
I think there are many things to think about. Number one is understanding their frame of reference, having some cultural competency around that, and understanding for a lot of Black patients, their only reference to research and clinical trials is the Tuskegee syphilis study. So understanding that there is intrinsically mistrust in the system becomes important in how you educate someone around a clinical trial. And really understanding that the questions that they ask you have this sort of frame of reference. So approaching the patient actually with some humility as well. Understanding your own biases and your own references. I think in medicine in general, we tend to view ourselves as the authority, if you will, having more knowledge than anyone, and really recognizing that patients need a level of humility in order to build trust with that individual physician is incredibly important. I think also having researchers that are part of their community, having diversity in leadership and investigators. Again, part of where we build trust is having patients see investigators that come from their community, people that they know have their best interests at heart and have a frame of reference that they can understand, I think is incredibly important.
And one quick question, did you ever persuade that patient to join?
I did. I did.
For you.
And it was, you know, and as I mentioned in my video, it surprised me that they actually thanked me for even considering them to participate, because again, they come from a frame of reference where they felt excluded from clinical research. So it was really eye-opening, I think, for both of us in our conversations with each other.
Finally, I want to turn to Adam Sharp. Adam, in your video, you told a story about your grandmother who sadly passed away from COVID. She was treated quite well in a hospital in Utah. And you juxtapose that to some of the instances you saw in the emergency room of your hospital in Southern California. And you were left wondering about unequal treatment. What are your thoughts today about that issue and what a solution might be?
Yeah, thank you for the question, Jackie. I think we are past the point by which we should be discussing if there are disparities and if there are inequitable care pathways. And I mean, we're past that. And the question is how do we change? As I mentioned, I'm fortunate to be kind of the picture of privilege, and so is my family. And my grandmother still died. And so there will still be bad outcomes that we can all relate to. And I think we need to be willing to have uncomfortable conversations. We need to be willing to change our system and have transparency, as was mentioned before, about transparency related to everything in healthcare. Everything's so muddled. It's hard to see what's what. We want to paint a good picture. And I think, as was mentioned, that doesn't create trust, especially when we don't know. So I think reaching out of the health system to bring, you know, novel strategies of people of color into positions of influence, whether that be as physicians or researchers, as was mentioned, and bringing in those people that are experts in helping those with social needs, whether that be housing or food or transportation, I think is the next step for the health system to really make some structural changes.
Adam, you and I started talking probably 5 weeks ago, maybe a little longer. And I'm wondering if since we first started speaking, have you seen changes in the ER in terms of bettering the care, or maybe even still having stumbles? What's happened there?
So yes, I think we have all learned, as was mentioned, from the experience of others, both in our country and outside of the country. So there's a lot more confidence in the healthcare staff and the physicians and nurses. We're not terrified that we're going to get this disease and die. Not that we don't recognize we could, but we're not as terrified. We feel like we have a better understanding. We've changed our triage process. So we're better equipped, and we have a couple of medicines we think, based on research, can help patients. The sad reality is I'm still seeing, as we've all seen, a much higher proportion of patients of color who are the ones that are coming in with this virus. And that's due to things that I think are completely outside of the health system, related to their housing situation and the jobs that they are employed in. And that's something the ER can't fix without, it's outside the health system.